Hello friends, welcome to our new video. Here we are starting with a new series about Robbins pathology. This is specially designed for those students who are not able to read Robbins completely due to lack of time or who don't want to read that bulky books but at the same time don't want to miss out facts from Robbins and concepts from Robbins. So this series is for you, and to get further updates, like, share and subscribe to this channel. So let's start with multinodular goiter. This is our first video. We are starting with multinodular goiter. In upcoming videos, we will complete first endocrine system, then we will move to other systems, and lastly general pathology. So this is first video, multinodular goiter. Here we are discussing about how it develops and what Robbins says about development of multinodular goiter. This is normal thyroid gland, which contains many follicles. Usually, follicles are lined by cuboidal epithelium in normal state. When gland becomes hyperactive, they change to columnar epithelium. Now, this is normal thyroid. When iodine deficiency occurs, here iodine deficiency is occurring, then T3, T and T4 levels go down. This will stimulate TSH release from anterior pituitary, and TSH will stimulate thyroid gland, and this will result into proliferation of cells to compensate T3 T4 and maintain normal level of T3 T4. So this goiter, so this proliferated gland which is increased in size and we called it as goiter, this gland functions to maintain T3 T4. When external iodine is supplied in form of thyroxine etc. or dietary iodine is increased, the gland comes to its normal size. Now in this case patient thinks that now swelling is disappeared, so we can stop medicine, and patient stops taking L-droxine tablet. Then again iodine deficiency develops and again goiter occurs. If this cycle is repeated for some If this cycle is repeated for some time, then thyroid escapes this cycle. It gets irritated. It escapes this cycle. And here you can say thyroid has escaped from this cycle. And now here are two follicles about which further crisp of this topic is here. Now see here, this is one follicle, this is one follicle, this is one follicle lined by cuboidal epithelium. Center here is colloid at center. Now in first case, due to this repeated process, this cell which is highlighted circled is undergoing mutation. Mutation in TSH receptor signaling pathway, which mediates proliferation of thyroid gland. Now, due to this mutation in TSH receptor signaling pathway, this cell will proliferate independent of TSH levels. Means if there are low TSH, in this case also this cell is going to proliferate. That means proliferation of this cell will occur irrespective of TSH levels, whether it is low or high. So, and all the cells derived from this cell are identical to this cell, and all will be derived from this single cell because only one cell is undergoing mutation. So we called it as monoclonal proliferation. Single cell giving rise to many cells. So monoclonal proliferation. And in this case, two or more cells from that follicles undergo mutation. The same mutation is occurring in these cells also, but here two cells giving rise to many cells. So in this case we called it as polyclonal proliferation. Two cells giving rise to many cells, hence it is polyclonal proliferation. And this proliferation is independent of TSS, so we call it as autonomous. Cells become autonomous. This is central part of multinodular goiter. Why that occur? Due to mutation. Why mutation? Due to repeated process of involution and proliferation. And this proliferation lead to irregular growth of follicles. First size of follicle was like this, but now it is changed to this due to monoclonal proliferation, and in this case due to polyclonal proliferation. Basically this monoclonal and polyclonal, these differences at cellular level, but grossly both represent as irregularly enlarged follicles due to proliferation of follicular cells. And finally this haphazardous enlargement of follicles lead to formation of multinodular goiters. In this case, here one follicle is proliferating, here one follicle is proliferating. Like many follicles proliferate in different manner. They don't resemble in size and shape, hence gives rise to multinodular goiter. So at the end, core concept is multiple episodes of involution proliferation cycle that leads to TSH receptor signaling pathway mutation. This mutation leads to autonomous proliferation. Autonomous proliferation of follicles lead to enlargement of many follicles which grossly gives rise to MNG, multinodular goiter. So in whole process this is central part, and this also contributes in this mutation and autonomous proliferation also contributes in increased risk of malignant transformation in long standing goiter. When such transformation occur, one nodule become dominant, hard, rapid increase in size. Also there is a clinical point. Sometimes this patient present with pain. Why pain? Due to proliferation vascularity increases and intranodular hemorrhage may occur, which will give rise to pain. So, pain generally indicates hemorrhage inside the nodule, and when we take a gross section of this nodule, cut section of this nodule, we will see multiple foci of hemorrhages inside that nodules. So this is overall pathology of multinodular goiter, and these are some facts facts said in Robbins. I hope you like this video, understood this concept. In case of any doubt, you can ask freely. Contact information is given in description, and also this flashcard and flowchart is shared in description. You can refer it, download it. Thank you.